Exit tumor. Precise planning is important to achieve accurate and optimal ablation. The tumor location related to the adjacent organ is the key factor in choosing the devices and the exact site of placement of each device. Peri-vascular or subcapsular location has been considered as the well-known factors affecting technical difficulty and therapeutic outcomes. Based on my experience on liver tumor ablation, whether there is the exit of tumor along the potential electrode path may be a good indicator to more sophisticatedly select the ablation devices, either single or multiple applicators. Conventionally, most operators prefer to use a single, more powerful applicator by placement along the central long axis of tumor. After single ablation for substantial time, 6 to 12 minutes, we finish or add more overlapping ablation depending on whether ablation zone covered the index tumor with adequate ablative margin. So, when we use single applicator, the certain area beyond the posterior margin, so-called the exit of tumor along the electrode path, is necessary to place the electrode tip and achieve posterior ablative margin. However, many tumors in daily practice often don't have enough space beyond the posterior margin of a tumor. In this scenario, there is two risks in terms of safe and complete ablation. First, if we place the electrode too deeply, there is a possibility of thermal injury to the adjacent organ. Second, if we don't place the electrode posteriorly enough beyond the posterior margin of the tumor, posterior ablative margin is often insufficient. So it is necessary to find the proper electrode path beyond the posterior margin of tumor. If there is not enough space beyond the exit of tumor, I would recommend not to insert along the central axis tumor, touch-through technique, but to use no-touch technique either by single overlapping or multiple simultaneous ablation. Many subcapsular tumors is posteriorly deep-seated tumors. Even in centrally located tumor, the periportal or peri-hilar tumor often provide the similar problem. Here is an example of exit tumor. We can see the enough space beyond the posterior margin of the tumor. In this case, we can use the conventional central touch-through insertion like this, and then so-called centrifugal ablation can be done. On immediate post-op CT, you can see the complete ablation with sufficient posterior ablative margin. What about this case? There is no space beyond the posterior margin of tumor along the potential electrode path, so we can call no exit tumor. This is quite common in our daily practice. For this kind of no exit tumor, I would recommend not to use the central through puncture. I used 2 electrodes, no-touch parallel insertion, and central Applicator ablation for 6 minutes. An immediate post-ablation CT, you can see complete ablation with sufficient posterior ablative margin. In summary, no-touch approach may be better to more confidently achieve sufficient posterior ablative margin, especially for so-called no-exit tumor, irrespective of the number of applicators. No touch may be better than the central puncture, especially for no exit tumor. Thank you.